You are welcome to my channel. Thanks for visiting. Today, I will be taking you through an excerpt from the full presentation on the prostate cancer already published by me. If you want to listen to the full presentation, you can go through this link. This link will lead you to the presentation that will take about 4 hours plus. That will cover the anatomy of the prostate gland and the neighboring structures. We will also address screening and the associated controversies, the arguments for and against screening, all right here. Also, you'll be able to see the associated risk factors for prostate cancer, the signs and symptoms already included, and how to make accurate diagnosis of prostate cancer found there. Not only that, this is just an excerpt. The treatment is just an excerpt. The treatment is also included here. You can see that it will take a long time to have full presentation of that magnitude. Now, if you don't have the time to go through the lengthy presentation through this link, and your concern is only about treatment, maybe you are about to make your selection as to the duration of the treatment, the doctor had explained to you that you are still concerned, then this is the best for you. As per treatment, this will take you about an hour plus and you are done. But kindly remember to subscribe to my channel, to drop your comments, give me thumbs up or thumb up. If you want to give me only one, I appreciate it. Thanks. Let's go. Now, treatment. The first part of treatment is you do nothing. You carry on with surveillance. You wait patiently and be watchful. This will be applicable if we are dealing with older men, or there are other associated terrible comorbidities that would have reduced the lifespan or expectancy to nothing more than 10 years. Or it is a small cancer that is limited to the prostate gland alone. And also, it is not growing aggressively. Even if it is growing aggressively, but the life expectancy is less than 10 years, will do nothing. There will be no serious symptoms here that will be associated that will warrant intervention. Because if we find that, except that if the man is so old enough and close to the grave, then we'll still have to do something. Okay, when it comes to watchful waiting, what we'll do is frequent follow-ups. We'll continue to monitor the signs and symptoms. And then we'll be taking blood sample for prostate-specific antigen. Many other tests we may not do. We may not have to bother the life of the person so much. The active surveillance will take the following pattern. We'll be monitoring this man very closely with PSA every 6 months. We will do digital rectal examination every year. Biopsy could be done every 1 to 3 years. Then we will do other investigations like magnetic resonance imaging, CT, PET, as it deems fit. So we won't just leave the person like that. The group where we will be doing surveillance will be younger age group with small gland that is not growing aggressively. Let me take that again before we leave this page. surveillance would be appropriate in an individual with life expectancy greater than 10. The tumor is not aggressively growing, it is slowly growing and is limited to the prostate gland. In that case, because it's not necessary to subject an elderly man with life expectancy less than 10 years with other comorbidities to the rigor of PSA every 6 months, digital rectal examination every year, biopsy every 1 to 3 years, doing MRIs. They are not necessary. The surveillance is necessary. When this man has more than 10 years life expectancy, still young, maybe 60 years, 45, 50, but the tumor is still small. It's not aggressively growing. And the symptom is not getting worse. So we'll continue with surveillance. Okay, let's examine brachytherapy. Here, we'll be dealing with radiotherapy. It has other names. Some call it seed implantation. Some call it interstitial radiation. Here, we're going to use small radioactive seeds called pellets. They are very tiny, like grain of rice, right? These pellets will be implanted into the prostate gland that is cancerous. You know that we can't do that with naked eyes, right? We use ultrasound and MRI. Sometimes some people will combine both. It may be adopted if the cancer is non-aggressive. And we have picked the cancer at the early stage of it. Fine, we'll go for that. We may not use brachytherapy alone. It is possible we combine this with other forms of treatment. We don't use brachytherapy when we are dealing with numerous foci of the cancer cells, in prostate gland. We can use these under general anesthesia. And some people will opt for the regional anesthesia like spinal anesthesia. So it may be for a short period of time, temporary brachytherapy. If we are going for the option of temporary brachytherapy, the individual will be given high dose of the radiation. So the radioactive pellets will be that of the high dose for a short time, like few minutes, 15 minutes, and that will be one treatment. It is possible you give more than 2 of such over 2 days. Okay, we must be very precise on what we are going for. High dose for 15 minutes, and you repeat that for 2 days, and you stop that cycle. Then permanent brachytherapy, we are going to use low dose radiation. The seeds here will be like iodine 125 or palladium 103. Will be implanted inside the prostate, right? And it will remain there and be releasing low dose of radiation, for weeks and months. Unlike the temporary that we're going to go give for 15 minutes, and then you do that 2 days in a week. Since the radiation will not be going far, we are sure that damages to closed structures is going to be minimal. However, we'll still be dealing with some side effects. It is possible that the seeds, or other names is pellets, of the radiating particle could radiate to the people around you. So you are a man, you're on brachytherapy. The type you have chosen is the permanent brachytherapy, is already implanted in you, and then you are home, your wife is pregnant. Be careful, she might take some doses from you. Okay? And or you have a little child and you are the same person helping to cuddle the child, to change the diaper or everything like that. Be careful, you might be passing the radiation to the little child. You may excrete or ejaculate some of the seeds. So that is why if you have to still relate with your wife, I'm not going deeper more than that, you use protection, condom. Inflammation of the rectum is a possibility, so proctitis, okay, because we'll likely go through that means. Urinary incontinence is a possibility with irritative symptoms, right? Then, because we'll go through the urethra sometimes and then get it implanted, there might be urethral stricture leading to obstructive uropathy. And of course, all our interventions will likely end up with erectile dysfunction. Another form of intervention is the use of radiopharmaceuticals. Example of such would be Pluvicto. So in this case, the radiopharmaceuticals will be targeting prostate specific membrane antigen. These PSMA will be found in large amounts on the prostate cancer cells. So when you grab your Pluvicto, you inject intravenously. That will reach PSMA in the prostate gland. Then it will release the radioactive agent there, killing the cancer cells right there. It is pretty successful on its own many times, but it will be better or advisable to shrink the tumor with chemotherapy before giving radiopharmaceuticals. PSMA PET scan is necessary before the onset of the use of radiopharmaceuticals. Why that? We need to be sure that the target cells are in the system, because if prostate-specific membrane antigens are not there, radiopharmaceuticals will just become poison. Yes, that is the right word. Because if we don't have PSMA and we give radiopharmaceuticals, those are the target cells, and they are not there, then it's going to start working to target any cells it could find. And that is toxicity, which is a form of poison. But if that is not the case, if the target cells are there, then the side effects will reduce. So PSMA PET scan will help to say, oh, the PSMA is right there. So go and grab that radiopharmaceuticals, inject it, and that will work. So that is the best way to go about radiopharmaceuticals. Okay, external beam radiation therapy, we won't waste time on that because we're all familiar with X-ray, right? so externally delivered. In this case, it is going to be useful for early stage of prostate cancer when our target is to cure, and also pretty useful for the very, very bad stage of the cancer that has metastasized to other parts of the body. So either early or terribly, terribly late, aggressively spreading external beam radiation therapy could be helpful. Here, we are going to use higher doses of radiation, and then we'll be targeting the tumor directly, okay? Then we will have to employ services of three-dimensional conformal radiation therapy. This one can locate the tumor on the prostate gland itself and deliver the radiation to the specific site. Isn't that great? Then also, it is helpful if we can make use of intensity modulated radiation therapy. That is an improved version of the three-dimensional conformal radiation therapy, in the sense that it is the most used of external beam radiation therapy for prostatic carcinoma. Here is going to make use of image-guided radiation therapy with the capability of precise delivery of the radiation in several angles to the prostate gland. And here, since we are making use of image-guided radiation therapy, the image will let you deliver directly to the prostate gland. So collateral damage to the neighbors, the closed structures, is appreciably reduced. Then you can move further a bit, that you can use volumetric modulated arc therapy. The arc there means it's going to rotate around the body and the radiation will be delivered. So intensity modulated radiation therapy takes weeks to be delivered. Then we can also have stereotactic body radiation therapy. Here, we are going to use large dose with a precise location. This will take several days to be completed. And finally, we can have MRI guided radiation therapy. That would be awesome, right? There's nothing good without side effects. Radiation is not good, but in someone with cancer, well, you are just looking for a way out to, lead a good life before, whatever will follow. Yeah. There may be inflammation of the rectum. Then sometimes bowel incontinence, urinary incontinence can happen, rectal stricture, rectal leakage. In fact, there may be impotency, and some call it erectile dysfunction. There is likelihood of trouble with the bladder, with radiation cystitis. There may be diarrhea, the fatigue, or lymphedema. All this could occur when anyone is on radiation. Now, the big topic, hormonal therapy. By way of introduction, testosterone is an androgen produced in the testes, adrenal gland, and prostate gland, but mostly produced in the testes. This testosterone is the strongest ally to the prostate gland when it comes to its survival. Testosterone helps the prostate gland to grow. So, the intelligent ones, the experts, decided that there's a way to punish the aberrant prostate gland that is now producing cancerous cells and is growing abnormally, trying to kill this one. So they concluded that we're going to cut off the food supply to this stubborn organ. And they've decided, let's do something. Let's cut off the androgen. That is why some call it androgen deprivation therapy, meaning testosterone deprivation therapy. This can stop the formation of prostate gland cells. It can prevent it from reaching, it can prevent testosterone from reaching the prostate gland. And that can later kill the cancer cells by way of starvation. If the cells still find ways to grow through another means, it's going to be very, very slowly. Like I said, some will give it another name, androgen deprivation therapy. But remember the adrenal gland. Remember hypothalamic pituitary adrenal axis. When the hypothalamus is releasing and controlling what the pituitary gland is producing, sending signal to adrenal gland to produce the hormones there. The same way, we will remember hypothalamic pituitary gonadal axis, where the hypothalamus will be sending signal to the pituitary, who in turn will send signal to the testes, where testosterone is produced in lady cells. We use this. Well, let me move to the next slide. Yeah, we've understood what hormonal therapy is all about. We can use it alone or in combination with other methods of treatment. When metastasis has occurred, hormonal therapy will still be pretty helpful. Wherever the prostate cancer cells are located, when we deprive it of testosterone supply, it's going to solve it there. We can also use this when the plan is to have radiotherapy with external beam radiation therapy. We can use this 3 months before we will use the EBRT. What we want is the prostate to shrink in size. And it will be better in locally advanced prostate cancer when we have used the hormone therapy preceding the use of the external beam radiation therapy. Then it would have reduced in size. We want it to shrink so that the radiotherapy will be able to hit it better. So I've gone through the uses together, right? So there are 3 ways to do this. We can do this castration, because when testosterone is cut off, we are castrating it, okay? So we can do this castration surgically by removing the testicles. In North America, they call it testicles. In Europe, they call it testes. So either way, we get it off, or get them both off. Then we tag that as ocheectomy, okay? It is hormonal therapy because we are removing, our aim is to remove the source of androgen, testosterone. So surgically done, ocheectomy. If that is not the option, Then we can have anti-androgen pills. Or the third option is luteinizing hormone releasing hormone, LHRH. Don't worry, I'll go into details of each of these very soon. As a matter of fact, when we are using LHRH antagonist, we will still need anti-androgen pills, in the face of flare. So that is how hormonal therapy will work. Let's see other things. Okay, luteinizing hormone releasing hormone. Remember, I have said hypothalamic pituitary adrenal axis and hypothalamic pituitary gonadal axis. The LHRH will be sent into the circulatory system by the hypothalamus. Okay? Then that will act on the pituitary gland, anterior pituitary, to release luteinizing hormone. That is hypothalamic pituitary, right? Now, hypothalamic pituitary gonadal axis. The luteinizing hormone from the pituitary will act on the testes or testicles, specifically the Leydig cells, to start producing testosterone. Remember, I decided to use hypothalamic pituitary adrenal axis also because the adrenal gland is capable of producing sex hormones, the androgen, from the adrenal cortex. So the impulse from the hypothalamus to pituitary to the gonads or adrenal axis will be cut off when we adopt luteinizing hormone releasing hormone as a form of treatment. Now, there are two ways. Either we use luteinizing hormone releasing hormone agonist or antagonist. Let's consider the use of the agonist first. This will block pituitary gland from producing luteinizing hormone. Luteinizing hormone releasing hormone is also called gonadotropin releasing hormone. It will initially stimulate the luteinizing hormone production, and then that in turn will work on the testicles or testes to produce more testosterone initially, and that is called the flare. Okay, the persistent presence of luteinizing hormone releasing hormone agonist will cause a form of fatigue as per luteinizing hormone production, and subsequently cut off the testicular capability of androgen production. That is, cut off the power to produce testosterone. The use of LHRH here is called medical castration or chemical castration. Remember, I said chemical castration or surgical castration. Surgical castration is orchiectomy. This is medical. The agonist here, example would be leuprolide, goserelin, or triptorelin, will be administered in form of injection or implant every 1 to 3 months. The flare here, which will be the overproduction, sudden acute overproduction of testosterone, will lead to obstructive uropathy, spinal cord compression, or bone pain. So that is what we do with the agonist. Now the antagonist. Here, luteinizing hormone releasing hormone antagonist is also called gonadotropin releasing hormone antagonist. This will work differently in the sense that what they will do is to block the site of LHRH on the pituitary gland. So when that is blocked, it's going to prevent the production of LH. And when LH is not in the circulatory system, there's nothing reaching the gonad to stimulate the production of the testosterone, thereby halting or stopping the production of testosterone from the testicles. Good news here is that we don't have flare when it comes to the LHRH antagonist. We have two examples. The first one I'm going to talk about is the degaredis. That one is the injectable form. We also have relugolix. That is the one we can give per oral. Those are the two LHRH antagonists. Remember, lady cells in the testes or testicles will be responsible for the production of testosterone, while the Sertoli cells will be responsible for the spermatozoon production. And adrenal cortex has the capability of producing aldosterone, cortisol, glucocorticoid, the androgens, and estrogens. So that is how we use LHRH. Still on hormonal therapy, let's have a look at anti-androgen pills. Here we have an example like flutamine, nilotamine, apalutamine, darolutamine, or enzalutamine. The commonest one with the brand name Calcidex is what many people will be familiar with when it comes to prostatic cancer. Okay. Another anti-androgen is spironolactone. That is used as diuretics in treatment of acne or vulgaris and so on. And sapropterin is used in polycystic ovarian syndrome in women. We are out of all those right now. So let's be back to example like Calcidex. In total androgen blockage, we will do something different. We will use these anti-androgen pills that will be given per oral, and we'll combine that with ocheectomy. That is surgical castration. We're going to remove the testicles. Or we'll combine that with luteinizing hormone, releasing hormone. Most of the times when it comes to prostatic carcinoma, we will use LHRH and use anti-androgen pills to tackle the flare. Now that is the surge of testosterone, following the administration of LHRH before the full effects will set. What the Calcidex will do here, the anti-androgen pill will do here, is to block the androgen receptor cells where the testosterone is expected to bind. They will go there to competitively bind to the same sites. So even if the testosterone is available, it's going to be useless because the binding sites would have been occupied by Calcidex, the anti-androgen pill. So the cancer cells will not be able to make use of the testosterone and then be starved to death. After the use of LHRH or surgery with ocheectomy, we don't fool ourselves to think that testosterone production is completely halted. No. Because there is that likelihood that adrenal glands and some surviving part of the prostate gland can still be producing testosterone. So we will still continue to use Calcidex to block the effect of the extra testicular production of testosterone. So all we want is starve the stubborn prostatic cancerous cells to death by cutting off the only food they like, which is testosterone. Now, ocheectomy. This is the surgical castration. It is irreversible. And here, like I've said repeatedly, you are removing the testicles. That is the source of testosterone chiefly. But that is not the only source of testosterone. But majorly, it is from the testes, hypothalamic pituitary gonadal axis. It is irreversible, like I've said, so it is permanent. The need for other treatment modalities is also applicable here, because even when you have removed the testicles, you might have the need again to remove the cancerous prostate gland itself. Then you can embark on radiation or radiotherapy. Your surgeon may choose to have incomplete removal of the entire testicle, and that will be subcapsular ocheectomy, where the inner part of the testicle alone is removed. You might join the women, the postmenopausal women will be battling with hot flashes. And then infertility can set in, or with erectile dysfunction. That is why it is advisable to have that robust conversation before you sign the contract to have this done. Most of the people that will choose this option will rather choose this option because they have metastatic adenocarcinoma of the prostate. And then they will have this as one procedure done and for all, while others will still choose estrogen in place of this. It could be done using general anesthesia if you choose, or the regional anesthesia as your choice may be, after proper explanation. One other side effects besides infertility, erectile dysfunction, and hot flashes would likely be that you have anxiety and depression, because permanently this is done. All you can have is processes, if you want, I don't have to go into that, so let me skip. So that is what ocheectomy is all about. When it comes to castration and prostatic cancer, for the sake of those who will need this for paperwork, or for medical students or nursing students, is all about what I've said about hormone therapy before now, but I can cap it off all within a few minutes. Androgen deprivation therapy, either ocheectomy or luteinizing hormone, releasing hormone, or anti-androgen pills, will all be what we are going to adopt here. But in addition to that, we'll do some other things more when we just don't want that prostate to get testosterone by all possible means. Remember, hypothalamic gonadal axis, as far as hypothalamus and luteinizing hormone, releasing hormone, and then pituitary with luteinizing hormone, and then the gonad, that is the testes or testicles, the lady cells producing testosterone. Remember, hypothalamic pituitary adrenal axis as hypothalamus, pituitary, and adrenal gland producing testosterone. Now, the hypothalamus releases LHRH, that will act on anterior pituitary that produces and releases luteinizing hormone. The luteinizing hormone will act on the target cells, here lady cells in the testicles or testes. The lady cells will then produce testosterone, which is the androgen. Remember, we're dealing with androgen deprivation, right? Okay. Then the androgen fills the prostate gland, making it fat, deprivation of which is termed castration. It could be chemical, like we're given this medication, or surgical, when we have ocheectomy. Also, hypothalamic pituitary adrenal axis can produce testosterone. And the anti-androgen pills will be in two generations. The first generation will be glutamine, beta-glutamine, new-glutamine, and so on. The second generation will be enzalutamide, apalutamide, darolutamide. They are better than the first generation. And someone will ask me, how come that they're better? Adrenal glands and the prostate gland can still continue to produce testosterone. This is where I'm going. That's why I'm bringing this out separately. Can still continue to produce testosterone even in the presence of those anti-androgens. Then we look for something different again to block the synthesis of testosterone completely. Okay? The extra testicular production of testosterone is in small quantity because the highest production of testosterone is right inside the testicles, precisely in lady cells. But the small amount that will come from outside the gonad could do enough damage. Could be powerful enough to enhance the growth of the cancerous cells. So, what are we going to do? From cholesterol, an enzyme called cytochrome P17 helps in testosterone production. In the testicles, from hypothalamic pituitary gonadal axis and adrenal gland, and then also from the prostate gland tumors. That CYP17 enzyme will be targeted by a particular set of medications: abiraterone, ketoconazole, and aminoglutamate. Remember, the sound of ketoconazole should give you a clue that this medication is also useful for something else, right? I know you know, like for fungal infection. But ketoconazole is not only useful for fungal infection, so it's for fungal infection, could work as anti-androgen and could work as anti-glucocorticoid. Some metastatic prostate cancer cells are castration sensitive, while some of those prostate cancer cells are castration resistant. Meaning, you will do all that I've said before this very slide, yet you will not be able to get rid of them. Those are the castration resistant. Then we can use combination of medications. Either we want to deal with castration sensitive so badly that it will be completely castrated, or we are envisaging that it could be castration resistant. So we will combine strong medications from the onset to deal with it seriously. In that case, we can go for the following combinations: abiraterone with prednisone for metastatic prostatic cancer cells, abiraterone with enzalutamide, that is second generation antiandrogen with abiraterone, ketoconazole with glutathione. Remember that glutathione is an hypnotic sedative agent, okay, meant for some other conditions, but useful as second-line agent in castration-resistant prostate cancer cells. So even when we have done everything and it's like we're not winning with the hormonal therapy, we can still calm down and grab ketoconazole with glutathione, or grab abiraterone with enzalutamide. So abiraterone with prednisone, all will help in castration-resistant prostatic cancer cells. The side effects of hormonal therapy: gynecomastia from antiandrogen pills, stress from daily intake of anti-androgen pills and estrogen. Remember, estrogen can give DVT that will go on to become pulmonary embolism, heart attack, stroke, and partial stroke. All the interventions can lead to erectile dysfunction. Flare can occur at the early parts of the use of LHRH, an agonist. LHRH must be taken every 1 to 3 months. For some people, that is enough straight, right? When you are selecting, remember, When you choose osteoectomy, that is surgery, it is irreversible. Osteoporosis can set in. Bone mineral density can drop, and easily you can fracture your bone. Hot flashes can be occurring just as your wife that is above 50 years will be having it, then you'll be having it also. And that is a troublesome condition, right? You may become unnecessarily tired, and there may be increased muscle loss. You might have memory fog, and you can have depression with increase in weight. The penis size might reduce, there may be loss of hair. And when you're on steroid for too long a period of time, you can come down with type 2 diabetes mellitus. Anti-androgen pills can also cause hepatitis. So, something different will happen. And that is called intermittent dosing. So let's get to the next slide. Okay, someone is about to choose hormonal therapy, but you are afraid of the side effects that I've just gone through. There's another way out. You can have what is known as intermittent dosing. Okay, here, you are going to take that hormone therapy and you'll be followed up with PSA level. Now they'll be calling you to have PSA level acid. When PSA, that is prostate specific antigen level, drops, and it drops very, very low, you'll be instructed to stop taking the pills. When you have stopped, you'll be, because it is reversible. Once it is not, the surgical procedure, it is reversible. So you will continue to regain everything you've lost, but we'll continue to monitor the PSA level. When the PSA level starts rising again, then you're going to start taking the pills again. In that case, before the side effects will set in or become horrible or unbearable for you, it's likely that the PSA level will have dropped to a point that will ask you to stop again. So you'll be able to decrease the side effects and enjoy more of your life. Chemotherapy. Because this presentation is pretty long right now, I will just be touching on the key points from this point and forward. Chemo is not curative, meaning there's no assurance that when you use chemotherapy, it's going to cure the prostatic cancer. We can use chemo under the following conditions. One, when the surgery has been carried out, we can use chemo for a short time. Some use chemo to shrink the cancer before surgery. We can also use chemo with hormone therapy. It is advisable to use hormone therapy first, but we can also use chemo when hormone therapy has failed. We use chemo in advanced prostatic cancer, not in early prostatic cancer. We don't go for chemo as the first modality of treatment when the cancer is still early. But in advanced case, yes. When it has metastasized, yes, we go for chemo. Examples of chemo that we can use would be docetaxel, cabazitaxel, mitoxantrone, extramuscin. We can also choose from the platinum-based chemo agent like carboplatin, oxaliplatin, and cisplatin. Docetaxel is the first drug of choice when it is all about prostatic carcinoma. We give this agent, that is docetaxel, with prednisone. I will explain why in a bit. The second that we can go for if we are not winning with docetaxel will be cabazitaxel. Now, the chemo will be given in cycles. You'll be given the time to rest. Then your doctor will tell you when you come back for the other cycle. Tell your physician any medication you are taking before the decision to have chemo will be made. Now, metastatic hormone-sensitive prostate cancer is another interesting one to consider. The first attempt here will be hormonal therapy with anti-androgen. Then you can opt for bilateral oophorectomy. All we want is to decrease testosterone. Most men will avoid surgery and will rather have medication. If that is the case, we can choose both chemotherapy with some of these anti-androgens. As a matter of fact, some will opt for chemotherapy and radiation. So those who will choose only pills, we can have triple therapy. That is anti-androgen. We'll give that with docetaxel, and we'll give that also with abiraterone. Remember the castration resistant stuff, right? So triple therapy, anti-androgen, docetaxel, abiraterone. You can also use drolutamide or enzalutamide when you are making your selection. Some will go for double therapy, not triple, like enzalutamide, with abiraterone. Okay. Docetaxel is given with prednisone. Abiraterone is also given with prednisone. So why prednisone here? This is just to add like a spoiler by sending a negative feedback to the hypothalamus that will in turn lead to the reduction in the production of testosterone. Remember hypothalamic pituitary gonadal axis and hypothalamic pituitary adrenal axis, right? When the adrenal gland or the gonad is receiving the impulse from the pituitary is receiving from the hypothalamus, and that is cut off somehow, then we are not going to get more production of testosterone. So prednisone here will block hypothalamic pituitary adrenal axis. So adrenal gland secretion of testosterone will be cut off. Okay. The prednisone will also help as an anti-inflammatory agent or anti-allergy. Remember, I will soon go through the side effects of this chemo right now, and let's quickly brush that. There could be nausea, vomiting, diarrhea. Some will have constipation. Okay, the white blood cells can drop, and that will lead to increase in infection from decreased immunity. Some will have bleeding and could manifest as bruising. There may be fatigue, loss of appetite. We all know that there will be hair loss, right? Mouth sores, and in fact, chemo fog in the brain. Some will have severe allergic reaction, even peripheral neuropathy with docetaxel and cabazitaxel. So you can see why prednisone will be pretty helpful. Besides blocking the hypothalamic pituitary adrenal axis, it's going to serve as anti-allergy at the same time. Chemo can also cause cancer on its own if you are named for a long time, like you are named for years. For example, leukemia. Leukemia can follow mitoxantrone use for a long time. There is that likelihood of increased blood clots when you are on extramostin. So with that, I've come to the end of chemotherapy. Let's move on. Cryotherapy. This is not commonly used, but for academic purpose, we can have a review of it along. So we all understand that cryosurgery is just about using very cold air or cold fluid anywhere to freeze unwanted tissue, right? Some call it cryoablation also. But this will be employed here when prostate cancer reemerges, okay? When you've treated and it's now repeating itself, it's reoccurring. Then you try something new, right? Okay. Never the first choice for treatment of prostate cancer. I'm going to repeat that. But it's pretty useful when we are dealing with early prostate cancer. And the prostate cancer is low grade. And it is also useful when this man cannot have radical prostatectomy. And this man can take radiotherapy. You say that instead of looking at the man, doing nothing, then we'll go for this, right? So there's no harm in that. You might be given general anesthesia or regional anesthesia with spinal or epidural. Then we'll go through transrectal ultrasonography to pass the cold gases, okay? The concern is what will happen to the urethra. That could be protected, from the severe cold by passing warm and salty water. So that is one way to get that done. The type of patient to be selected for this, besides what I've listed earlier, will be someone with small prostate gland, even with the cancer in it, okay? Because it's not going to help a man with large prostate gland. When you are thinking of whether to have cryotherapy before radiotherapy or radiotherapy before cryotherapy, it is better to have it before you have radiation, okay? Now, what are the possible side effects? There might be hematuria. The individual can be, bleeding. Definitely, erectile dysfunction. Fistula may occur between the rectum and the bladder. Then some come down with urinary incontinence, then swelling in the perineal region. There might be pain everywhere. So that is that about cryotherapy. Not many people will even try this, but when we can't make use of the rest, then we'll settle down, to have cryotherapy. Surgery. Here is all about prostatectomy. This is the way to excise, or we call it prostate excision. Okay? This is the surgery to remove part or all of the prostate gland. It might be simple or radical. I will explain further in a bit. You can have robotic assisted form, and you can have open surgery or laparoscopic surgery. Now, let's check the simple prostatectomy first. Simple prostatectomy is mostly indicated when we are dealing with benign prostatic hyperplasia, when the affected individual can no longer cope with the obstructive uropathy. This is a minimally invasive procedure. We can use robot-assisted technique, but no open surgery. No open surgery. That is simple prostatectomy. The segment of the prostate gland is removed. Not the entire prostate gland will be removed. No. And when that is the case, we'll say that that is simple. This will be as a result of obstructive uropathy with impaired storage of urine, leading to urinary frequency, urinary urgency, nocturia, or with impaired voiding, unable to void completely, and battling with difficulty initiating the menstruation. Some were poor stream and intermittent, urine stream. Then some will have dribbling after the voiding. Some were very slow and prolonged urination. They will have a feeling of incomplete empty. And the storage of the urine would have led to urinary tract infection. Then some will be down with oliguria, and complete obstruction can even lead to anuria. Hematuria hydronephrosis may occur here, and some will develop bladder stone. So when that is the case with benign prostatic hyperplasia, you call for simple prostatectomy. The second part of prostatectomy, or the second example, would be radical prostatectomy. In this case, unlike the simple, the entire prostate gland is removed. Lymph nodes surrounding it will be excised, will be removed for histopathological studies. You can use either robot-assisted means, like robot-assisted radical prostatectomy, or open radical prostatectomy, open surgery. Then you can ask me, what are the possible indications for this massive excision of many structures in the pelvic region? Number one, when the entire prostate gland is suspected to be removed, then it will be radical prostatectomy. If the cancer has not metastasized to distant organs, then surgery is reasonable. When it has metastasized to distant organs, there is no need torturing this man with either simple or radical prostatectomy. No more, no need. When the surrounding structures like seminal vesicles, vas deferens will also be removed, then it's going to be radical. Now, when oliguria or anuria has stepped in, meaning there is severe uropathy, then radical prostatectomy might be the expected intervention. We are battling with hematuria. In fact, nephrolithiasis due to the prostatic cancer, blocking the flow of urine, then accumulation of the element therein. So, stone in the bladder, stone in the kidney, slow urination, hydronephrosis. The other issue will be when we table every means of treatment and the patient chooses to have radical prostatectomy, then we can go for it. And also when the patient cannot take hormonal therapy, cannot take chemotherapy, cannot take radiotherapy, then what do we have left? and the life expectancy is still, more than 10 years, then we'll help him out with radical prostatectomy. So the other issue is the approach to radical prostatectomy. Now, it can be through retropubic approach, where you make small incision or any incision, and that is better, particularly in younger age group, because it is going to give better cosmetic effect. Yeah, and major muscles are bypassed. There will be less pain, and recovery will be faster than using the perineal route. Another type would be nerve-sparing prostatectomy. In this case, you want to do everything to preserve the erectile function. This will be helpful if the man is still young, and maybe, now you understand, I don't need to go into details. So you just do everything to bypass the neurovascular bundle. Now that will be by the sides, two of them on the flank of the prostate gland. So you want to preserve that. So, and also we can have laparoscopic prostatectomy with perineal approach. Like I have talked about retropubic approach, right? Majority will not use perineal route, okay? Majority of the surgeons will use retropubic approach, yeah, because of the advantages that I've stated earlier. You can pause and rewind and get the advantage. Robotic assisted laparoscopic prostatectomy is gaining ground. Many establishments are using that right now. The radical prostatectomy with perineal approach, like I said, is less encouraged now. More of retropubic approach, and perineal is okay if no lymph node removal is required. So it's not completely, out of sense or out of point that you use perineal approach. What about the patient that cannot use retropubic approach? We are left with perineal approach if we still want to go through either of the route. Let me just mention some possible complications of prostatectomy. The one that I can never forget is massive bleeding. I've seen that now in those days. So hematuria is another possibility. Then damage to what we call it collateral damage to the neighbors, the close structures there. Might be urinary incontinence later on. Nerve damage, if it is not sparing, then could lead to erectile dysfunction, inability to further a child in future, fertility. There could be swelling in the penile and scrotal parts. Then fistula could also form between the rectum and the bladder. So a lot, we will discuss all these, and if you use open laparectomy and then you have prostatectomy done and you use general anesthesia, the effect of anesthetic agents will still be there. So we'll discuss all this with the individual who needs this. When the solution remains palliative treatment only, I won't waste your time. Please click on these links to get full information about palliative treatment. When you are battling with nausea and vomiting, you get full information through this link, please. And chronic pain, you can get full information about possible interventions, medications to use, how to use them, all through these 3 links about chronic pain. When it is about infertility, please check this link. That will lead you to infertility in males and the causes and treatment. Everything is right there. Now, because we've been talking about erectile dysfunction all the while, I've listed some interventions here, but you are going to get full info about these subjects right here and here. So click on this link, go through all this, because that is the reason why many men who think they need this in their lives will not want to take any treatment. I bet you. But if you can find the way around it, then once this is out of it, they may take the treatment. So go through these links, please. Now, other systems and conditions that we can be battling with will be fatigue and insomnia, about central nervous system. There may be inflammation of the rectum. The skin could be damaged. There will be hair loss, particularly those taking radiotherapy and chemotherapy. The renal system can suffer post-radiation, and I have addressed infertility and erectile dysfunction. Other conditions would be depression and anxiety. Why have I decided to bring this out? And I won't rush to conclude without addressing it. Let's face the fact. We're all humans. The man who has just passed through the stress of all the long, difficult process to diagnosis, and who had just been given the bad news that he has cancer of any sort, let alone saying cancer of the prostate. And even if he's old, he won't take it just like that. Or let me say, he might not take it just like that. And it's worse when he's just about 50 or 60 years old. Because it's going to affect many things in his life. The next thing we should be concerned about will be anxiety and depression. So we have to have that open conversation, counseling and psychotherapy. And if we deem it fit, antidepressant or contact psychiatrist. Because the cancer may not kill the man. Your intervention may not kill the man. The man may die when depression is not handled, tilting him to suicidal thoughts, suicidal ideation, attempted suicide, and frank suicide. You see that it's pretty important to have counseling and psychotherapy and have antidepressant if that will suffice. Other medication like antiemetics, analgesics, and antidepressants will be used here. So not necessarily affecting the prostate cancer itself, but because we are dealing with a complete human being. So holistic approach is what I've presented here.